Medurstand Understanding Medicine.
I am Professor Aziz-ur-Rehman, and we have already discussed various aspects of ischemic heart disease, and this is the fourth and the final lecture in this series. And today we're going to talk about ECG localization of acute myocardial infarction. Now, of course, the most important thing is to be able to make the diagnosis of acute myocardial infarction, but it is perhaps also important to be able to localize the exact area of infarction. It could be anterior wall or posterior wall or lateral wall or inferior wall. And I think ECG is a great tool to help us make that diagnosis. So today we are going to discuss the role of ECG, first in establishing the diagnosis of myocardial infarction, and two, in its localization. Of course, the ultimate would be angiography, but you can have a reasonably good idea which vessel and which part of the myocardium is affected. Now, myocardial infarction actually evolves over time, of course, over just a few minutes. It just doesn't develop like an explosion of a bomb. It starts happening, and over a period of few minutes, it develops. And that leads to certain ECG changes. Now, depending upon when you actually see the patient, you would see different ECG changes. Now, I have drawn this cartoon to show you these changes. And let me first go through various steps. For example, this is hyperacute T wave. Now, this you will see only if you happen to see the patient within minutes. Somebody is already in the hospital and develops infarction, or lives very close by and reaches hospital in a very short time. So you will be able to see this hyperacute T wave. And this should not persist. If hyperacute T wave stays, that would suggest another cause. So it is a temporary change. Like in this one. So this is like normal ECG. Initially, there would be hyperacute T wave in those leads which represent that particular part of the myocardium which is infarcted. It would be followed by ST segment elevation and with the reciprocal changes. Now, whenever there is ST segment elevation, there would be some ST depression in the reciprocal leads, the leads which represent just the opposite part of the myocardium. Now, but the ST segment elevation is always considered to be the primary change. So your localization of infarction will be based on ST elevation. In this case, you can see this ST elevation in this lead. So, and then it would be followed by T wave inversion. Now, in myocardial infarctions, things occur one after the other, but while still the previous change is still there, the new change develops. For example, in this you have ST segment elevation, and in this you also have ST segment elevation, but T wave has started inverting also. All right, so I think there is an overlap of changes. So at any time you would have a combination of changes. Then finally, after hours and sometimes days, you develop the permanent change in ECG in the form of Q wave. This is the Q wave, and you have Q wave here also. Q wave is defined as a wave which is the first downward deflection, which must be at least one small square and must be 1/3 or 1/4 of the R wave in the same QRS complex to be significant. There may be normal small Q waves, but in this context, we will consider a Q wave as an abnormal Q wave if it fulfills these criteria. Now, finally, we have then normalization of STT. Within days, ST segment becomes normal, and the only change which persists for life maybe, that is Q wave. So Q wave represent old infarction. How old you can't determine. It could be a couple of days and it could be a couple of years. So Q wave is the permanent change. I think this should be helpful to interpret further slides. Now, let me explain the pathogenesis, how these ECG develop. Now this cartoon shows this is the blood vessel, this is the coronary vessel. You know, our coronary vessels are on the surface of the myocardium, and one branch runs into the myocardium. This donut represents myocardium. So suppose this artery is occluded, and as shown in this picture, it is completely occluded. So the circulation will be affected, and myocardial infarction will develop. And typically, it would start developing from the endocardium, and it will develop and then will involve the entire myocardium. So this is full thickness myocardial infarction. This would result in ST segment elevation myocardial infarction, and because there is what is called current of injury, this myocardium is permanently depolarized and it is producing current of injury. This current of injury is showing as ST segment elevation. You know, ST segment represent the part of depolarization. So since it is not depolarizing and it is showing permanent ST segment elevation, so this is the first sign of ST segment elevation myocardial infarction if you have transmural infarction. Now, what is happening in the opposite leads? You are recording, I think, reciprocal changes because current of injury is flowing this way. In ECG, you know that if current is flowing toward an electrode, it would record a positive or upward deflection, as in this case. And if the current is flowing away from the electrode, in this case, this current is flowing away from this electrode and it is recording it as ST depression. So this would be called reciprocal change. So you have primary change in the form of ST elevation in the affected part, and you have ST depression in the opposite part. So this would be very helpful when you actually interpret ECG. Now this is the other example, that this is non-full thickness infarction. Sometime occlusion may be not complete. Like in this picture, you can see the clot has not completely occluded the vessel, so it has caused critical ischemia but not full thickness infarction. In this also, myocardium will start necrosing from inner side, but it will not reach the surface. So it will cause only non-full thickness infarction. And in this case, current of injury is flowing away from the lead. So if there is a lead here, it would record it as ST depression. So typically in non-full thickness infarction, you do not have ST segment elevation. And also, this area is not truly represented in particular lead. It typically is shown in multiple leads. So I think we believe that in case of NSTEMI, non-ST segment elevation myocardial infarction, it is usually not possible to exactly pinpoint the artery which is culprit. Now again, this picture will help you to understand various changes in various leads. Now this is the cut section of heart. Now this is the anterior surface. You know the precordial leads. They are placed in a way that the V1, V2, V3, V4, V5 and V6. This anterior and lateral surface is one continuous structure. So on the chest we place these leads. So V1 and V2, they represent the septal part of the anterior wall, anteroseptal. Then V3 and V4 will indicate the apical part, and V5 and V6, they will represent the lateral part. So I think based on which leads show the changes, we would localize infarction. If all leads are showing ST elevation, then it would be called extensive anterior wall infarction. But if only these two leads are showing changes, it would be anteroseptal, then anteroapical, or the anterior wall, or anterolateral. So based on these leads, we will put a label of which part of the myocardium, which part of the anterior surface is actually infarcted. When it comes to inferior surface, because limb leads, they represent the inferior surface. Now you imagine somebody standing and this is the inferior surface of his heart, and limb lead 2, which is placed on the left leg, would represent the inferior side, and limb lead 3 would also, which is placed on the right leg, would also indicate the inferior surface, and AVF, which is in the middle. So limb lead 2, 3 and AVF, they would represent the inferior surface of the heart. So if the changes are present in these leads, we would infer that there is infarction in the inferior surface of the myocardium. And then we have these leads. Lead 1, if you are familiar with the lead placement, lead 1 is actually between left arm and right arm, and left arm represent the positive electrode, and then there is an AVL lead. So if there is infarction in the lateral part, upper part of the lateral surface, it would be shown only in limb lead 1 and AVL. Also, because the precordial leads pass in front of the heart and then go like this, these changes will also be shown in V5 and V6. So to sum up, V1 to V6, they represent the anterior surface of the heart. 2, 3 and AVF, they represent the inferior surface of the heart, and 1 AVL and then V5, V6, they represent the left lateral surface of the heart. So we have already learned the ECG changes, and now we know which group of leads represent which part of the myocardium. So that is how we localize infarction on the basis of ECG. Now, there are some morphological patterns which develop. Now, this I have tried to draw a full thickness myocardial infarction. This one is full thickness infarction. These three are non-full thickness infarction. This may be called subendocardial. This may be called subepicardial. This may be called endomural or intramural, but we do not use these terms anymore. We use the term non-full thickness infarction. So how these patterns represent various ECGs. So this is transmural, and this would surely result in STEMI, ST segment elevation myocardial infarction, if there is full thickness infarction. But all these three, they are non-full thickness, and they would result NSTEMI. This is subepicardial, subendocardial, and intramural. All are collectively non-transmural, and they would result in NSTEMI. So it is actually important to be able to make diagnosis of STEMI and NSTEMI because they represent different levels of damage. Types of myocardial infarction and ECG changes. In NSTEMI, I'm sure you all familiar with this term, non-ST segment elevation myocardial infarction. The changes are ST depression or no changes. Please remember, it is perfectly possible to have normal looking ECG, and at least to the beginner. ECG might just look normal or only slightly abnormal, or may show just subtle abnormality, no definite ST segment elevation. So the symptoms are those of acute myocardial infarction, but ECG does not show any ST elevation. It could show depression or no change, but no ST segment elevation. And this is typically seen in multiple leads, because I have already mentioned that it is usually not possible to exactly localize NSTEMI. And when we are talking about STEMI, that is full thickness infarction, then depending upon which lead you see the changes. If ST segment elevation is seen in V1 to V6, V1 to V6 all represent the anterior surface of the heart, then you would expect changes, and it would be called anterior wall myocardial infarction. So you can localize myocardial infarction based on the changes in which based on the leads in which you see the changes. Then if ST segment elevation is seen in lamellary 2, 3 and AVF, and we just learned that these three leads, they represent which part? The inferior wall. So there would be inferior wall myocardial infarction. And the third possibility is that if there is ST depression in V1 to V4, this is a little tricky because there are no leads which represent the posterior surface of the heart. So either we place additional leads V7, 8, 9 on the back of the chest, or we look for opposite changes in the opposite group of leads. So instead of ST elevation, if we see ST depression, and instead of posterior leads, we see the changes in the anterior leads, it would have the same interpretation. So if there is ST depression in V1 to V4, in a person who has symptomatically acute coronary syndrome and trop T is elevated, then it would represent true posterior wall infarction or just posterior wall infarction. So I think this is the theory part. We will practice on ECGs. So I think this should give you some idea how we localize infarction based on the ECG changes distribution in which leads the ECG changes are present. Now let's do some practice. I think it's time for you to interact. Do you see any changes? I'll give you some seconds. Then I will show you the changes. Maybe then you can find out. Just see if you see any changes. I don't see any ST elevation. How about T wave inversion? Yes, we have T wave inversion. No ST segment elevation here, 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 or here. There is T wave inversion in multiple leads, and this is perhaps NSTEMI if trop T is elevated. If trop T or trop I is done more than once in the proper window, if that is normal, this could represent something else, could represent some electrolyte abnormality, could represent old ischemia. But if trop T or trop I is positive, and this is the ECG, and this would represent a NSTEMI. So we have already made a diagnosis of non-ST segment elevation myocardial infarction. The criteria which we use, persistent and symmetrical. These changes are persistent, means that over at least few hours they persist and they are very symmetrical. Look at this T wave. This is very symmetrical. That means if I draw a line in the middle, both halves will be the same size and same shape. So symmetrical T wave inversion present in maximum leads, not only all precordial leads. You can see these changes here on the limb leads also. So, and T wave inversion in most leads, that is the only ECG criteria. So for NSTEMI, we use one criteria, that is inversion of T wave in multiple leads, and these changes, they persist for some time. So this was NSTEMI. So I think diagnosis of NSTEMI is relatively easy. But those who believe that ST segment elevation is the sign of infarction, they could miss this one. Now let's take another example now. Your turn again. See if you can find out any problem with this ECG. Remember, we are discussing ECG localization of myocardial infarction. So do you see any ST depression, ST elevation, T wave inversion? I can see ST elevation. Let me draw your attention to these leads. Massive ST segment elevation. Look at this ST segment, at least 3 mm elevated. This may be up to 10 mm. You have to, if you draw a line here, see how much ST segment is elevated. In V1, V2, V3, and I think all precordial leads is massive ST segment elevation. 10 millimeters average. So what is the diagnosis? The diagnosis is very typical anteroseptal myocardial infarction, right? So there is STEMI. This is ST segment elevation, because we see very impressive ST segment elevation. And why do we say it is anteroseptal? Because we know that the precordial lead V1, V2, V3, they represent anteroseptal part of the myocardium. So that is how we have made the diagnosis of anteroseptal myocardial infarction. In this patient, of course, we will need trop T, trop I to be positive, but ECG changes are so typical. This patient, I think, after this ECG, might not go for the trop test, and immediately further action may be taken. So what are the criteria we use for the diagnosis? ST segment elevation, we see it here, followed by T wave inversion, not seen in this ECG because patient has presented acutely. And pathological Q wave, again we don't see any Q waves here because it is the acute phase. If intervention is not done, if perfusion is not done, or if patient doesn't reach the hospital, then those changes will develop. Now this patient has got hyperacute phase or just acute phase of myocardial infarction affecting anterior wall, the anteroseptal region. Now this is another example. We are actually discussing various anatomical regions in sequence, so I think you may be able to guess what should be coming after anteroseptal myocardial infarction. What do you see? Do you see any changes here? Let me show you. Yes. In inferior leads, this is limb lead 2, this is limb lead 3, and this is limb lead AVF. And we know what is common in these three leads. They all represent the inferior surface of the heart. Alright, so this is definitely ST segment elevation in the inferior leads. So I think it is and there is reciprocal changes. This is ST depression in limb lead 1 and AVL. These are actually reciprocal changes. If you imagine heart, the inferior surface is here and then lateral surface is here. So actually this lateral part is actually being, imagine the shape of the heart is a globular. So these limb lead 1 and AVL are just opposite to limb lead 2, 3 and AVF. So ST segment elevation in inferior lead would reflect as ST depression in 1 and AVL. So primary diagnosis is based on ST segment elevation. So the diagnosis of STEMI is very obvious. ST segment elevation in inferior lead. So inferior wall myocardial infarction, ST segment elevation. So I think this was also easy. The criteria we use are same as we use in anteroseptal infarction, but their distribution is different. ST segment elevation, T wave inversion, pathological Q wave. In this patient, there is ST segment elevation, and perhaps there's a Q wave here also, but not in these lanes. I think this is also a relatively acute phase. So STEMI affecting the inferior wall. Now let's take another example. How about this one? I think, what do you see here? Any ST elevation here? No? Okay. Here 2, 3 AVF. I think there is some ST segment elevation here. Now let me show you the sign. These 3 ST segments are definitely elevated. And I think if you see carefully, you would also notice some ST segment elevation in V4, V5 and V6. Maybe less marked, but there is some. Okay. And then if you further examine this, if you draw a line here, you will notice that ST segment elevation in limb lead 3 is more than that in AVF. Actually, I should compare it with the 3 with the 2. Okay. So let's forget this one. You compare ST segment elevation in 3 with the same in lead 2. ST segment elevation in 3 is much more pronounced than in lead 2. This also has some meanings. This means that patient has got inferolateral ST segment elevation, marked infarction or acute coronary syndrome with right ventricular infarction. Now, how do we know this is ST segment elevation, marked infarction? Because there is ST segment elevation in 2, 3 and AVF and inferior wall, okay? Now, how do we know this is right ventricular infarction? Because right ventricular infarction occurs in the setting of inferior wall infarction, and there are other signs also, but one sign is that if ST segment elevation in limb lead 3 is more than ST segment elevation in limb lead 2, that could represent right ventricular infarction, because limb lead 3 reflect the right side of the inferior side, where the right heart is situated, right ventricle is situated. So this is actually inferolateral. And how do we say lateral? Because the lateral precordial leads are also showing some changes. I think this is slightly more complex. If you're able to make inferior infarction, that would be good enough. But I think a good postgraduate student would also come up with a diagnosis of right ventricular infarction and lateral infarction. So I think this is little more complicated than the previous one. How have we made the diagnosis? ST segment elevation and Q wave. In this patient, we have some Q waves also in 2, 3 and AVF. And then ST segment elevation in V4, V6, very subtle. And then ST segment elevation in limb lead 3, this one, and limb lead 2, this one is different. The ST segment elevation in 3 is more than that in 2, representing right ventricular infarction. Now, just to explain the concept of reciprocal changes, I have taken this picture. Now, this is the area of infarction. It is producing current of injury, and any electrode just on the top of this marked infarction would record as a upward deflection, this ST segment elevation. And same current of injury would be registered as ST depression in a lead which is placed just opposite to the infarcted part. So same phenomenon is shown as ST segment elevation and ST depression in different leads. We use the ST segment elevation to localize myocardial infarction. This may be slightly more tricky. Do you see any ST segment elevation? There isn't any. In fact, if there is anything, it is ST depression. Do we link ST depression with myocardial infarction? Normally, we talk about ST segment elevation when we discuss myocardial infarction, but this is ST depression, rather unusual. In V1, V2, V3, you see ST depression, and you also see that the R wave in these leads are little more prominent than normal. Normally, in V1, we have a very small R wave, in V2 maybe slightly longer, and then it evolves further in V3. They are unusually tall R waves, and then T wave is also prominent here. You can appreciate this T wave because T wave actually starts from here, so it is prominent. What do you say? ST depression and prominent T waves, they actually represent posterior wall STEMI. It is not ST segment elevation. We don't see ST segment elevation, but since we are looking at reciprocal leads, so ST depression actually represents ST elevation in the theoretical posterior leads. So it would be equivalent to ST segment elevation in the posterior lead. So it would be called posterior wall STEMI. The criteria ST depression and prominent T wave and tall R wave. These are just opposite to what we discussed earlier. ST depression instead of ST elevation, prominent T wave instead of T wave inversion, and tall R wave instead of a Q wave. So all opposite ECG changes, but in opposite group of leads in V1, V3. V1, V3 leads are on the anterior side. So they are opposite to the posterior wall. So they represent the true posterior wall infarction if the changes are also the opposite. I hope you were able to understand this one. It's a little tricky, but if you know the basic concept, I think you should be able to understand this ECG also. What do you see here? This we actually have already discussed, so I'll be a little quick to save time. I think you see the same thing as ST depression and prominent T wave. Here I think T wave is definitely very prominent, and you also see slightly prominent R wave. So this is I think also true posterior wall acute coronary syndrome or true posterior wall myocardial infarction. I think the same criteria. What about this? Whenever we discuss about myocardial infarction, we often talk about ST segment elevation, and this is another condition which can present with ST segment elevation, and it may also cause pain, chest pain. What condition can you imagine? A condition which can cause cardiac pain but not ischemic in nature, and it may also result in ST segment elevation. See, ST segment is of different types. It's concave upward. The ST segment of myocardial infarction is convex upward. This is concave upward. And two, the T wave is not inverted. When there is ST segment, T wave is actually elevated. T wave is upright. Now this is actually a case of pericarditis. Pericarditis sometimes develops as a complication of myocardial infarction also, but this ECG is from a person who has actually viral pericarditis, and the criteria are, I'm not sure if I've given the criteria, yes, criteria given here, ST segment elevation in all leads with concavity upward, because you can't imagine having pericarditis in one part and not the other part. So pericarditis would of course involve the entire pericardium, and it is characterized by ST segment elevation which is seen in almost all leads, and the ST segment elevation is usually not as impressive as we see in myocardial infarction, and morphologically ST segment is concave upward. You can appreciate it here. And no T wave inversion. T wave inversion will occur in pericarditis, but after the ST segment has normalized. In myocardial infarction, T wave inversion occurs while ST segment is still elevated. But in pericarditis, first ST segment stabilizes and then T wave inversion starts. So in one ECG, you would see either ST segment elevation or T wave inversion depending upon when the ECG was done. And there is upright T waves, and you will never see Q waves in pericarditis. So although we were covering acute ischemic heart disease, so I thought it would be relevant to discuss pericarditis here because it can present with the same symptom as patient with myocardial infarction, and it could have similar ECG changes. Of course, there are other causes of ST segment elevation, and I will be covering them. Just to remind you that I will have a whole series of lectures on ECG, and we will be discussing all kinds of abnormalities, chamber enlargement, electrolyte abnormalities, various types of ischemic heart diseases, dextrocardia, things like that. I think after we finish with the other main topics, we will definitely be talking about various ECGs abnormality. There will be actually a whole series of lectures. So this was So this was about ECG localization of myocardial infarction. So I think we have learned that ECG in NSTEMI there would be persistent persistent T wave inversion, no ST segment elevation, and changes will be seen in multiple leads, and it will be difficult to exactly localize the infractor part. But in ST segment elevation myocardial infarction, based on which leads you see ST segment elevation followed by T wave inversion followed by Q wave, you can localize myocardial infarction to the anteroseptal region, anterolateral region, inferior wall, or true posterior wall. So of course the ultimate would be to do an angiography to find out the exact area which vessel is affected. And but I think as an internist, as a postgraduate student, if you are able to make a diagnosis of acute myocardial infarction and if you are able to localize it, I think you have done a reasonably good job. So this was Professor Aziz-ur-Rehman from Medurstand. I am really looking forward to see you in my next series of lecture, which will be on some other topic related to cardiology. Thank you.